To remind you, tomorrow morning, 7:15 to 7:45, we have a non-CME event. Whoop. Well, I'll just do this one first. So this afternoon, when we're done at 4:20, we have a non-CME event. Amgen, it's on neuromyelitis optica spectrum disorder, treatment and safety profile. And then tomorrow morning, we have one at 7:15 to 7:45, and that's going to be with CIDP. And then another one at 4:10 to 4:20 or 4:40 on CIDP. So set your alarms, get up early, come and visit. So I know that the audience is a little bit skewed here, but we're going to do some Neuro Jeopardy as we go through here. Normally we just do, this group and that group. You guys don't have as many people, so you can always keep individual score as you go through. There's some stuff that's new. There's some stuff that's old from before. So if you've seen some before and you really remember them there, but there's some new stuff that's there as well. But if you see it and you think you know it, yell it out. Blake will keep score. He's not very good at addition. My understanding is he's better at subtraction. All right, so I flipped the coin, and the smaller group over here won. So Tim, Mike, so why don't you pick a category? For 50? Sorry, which one did you say? Oh, picture this for 50. So let me just see. Picture this for 50. All right, so picture this. Look at the lesion there. So what is this? That's the question. Blake? Anybody else? That's our stroke neurologist. He gave a talk earlier. Feel comfortable. Well, I mean, I'm not disagreeing with your vascular territory. Okay. Yes. It's your arrow. You put it on there. Yes, ma'am. Did you get? Yeah. What was that? Name the treatment. What are you given? Vitamin? Thiamine. Thiamine for Wernicke's encephalopathy. Sorry, Blake. All right, you guys lost. Maybe somebody won. Oh, my God. Oops. Oops, let me go back to the next picture. Okay, what do we have now? We'll go faster if the time sort of goes here. Oh, for God's sakes. All right, Tim, what do you got? Picture this 10. All right, oh my God, if Blake doesn't get this one, I'm not sure. Name the problem. He showed this picture. Yes. So basilar artery thrombosis, you can see he's got positive arrow sign right there. You can see up here as well. So hyperdense basilar artery sign, again, make sure you're using a non-contrasted CT scan. It's a predictor of acute basilar artery thrombosis, and obviously we saw some cases of this earlier. As a quick aside, a little bit fun, what is the relationship between the Beatles and the CAT scan? And I'm deaf, so you really got to yell it out if you know. What's that? Okay, so what's the relationship? You're on the right path. Hounsfield was the manager of the Beatles? No, but you're really so close. So, Hounsfield won the Nobel Prize for his work on the CAT scan for the Hounsfield units to try and look at various densities and predict what things are. But he was an engineer that was employed by the same group that employed the Beatles. And hence the revenue from the Beatles songs went to fund the research by Hounsfield, who then developed the CAT scan. So the Beatles are indirectly responsible for the development of the CAT scan. I think that's pretty cool. Let it be. It's a stretch? Is that it? Is that what you said? It's a stretch? That sounds like a negative criticism. I'm just trying to help here. All right, Tim, I'm picking on you. What do you like?
We'll go for 20. Picture this.
Picture this for 20. I like the way you go. Oh, this is so near and dear to my heart. Name the usual medication for this tumor. Does anybody know what this is called here around this cavity? Pseudopalisading necrosis. We have a large necrotic looking tumor. The tumor is what? Glioblastoma. So the standard medication for glioblastoma, what's the approved medication? Temozolomide, that's right. Good. All right, Tim, I know you're going to 30 next. All right, picture this. Name the likely acute problem with this patient. What's the disorder? When I checked the patient's vitals, the blood pressure was very elevated. Right. Oh, there we go. Now the critique is coming out. But that's why I gave you a little extra history just in case you needed it. My friend from Montana.
Who described us?
Oh. Now he's asking the questions.
Who sent it to the clinic? 1996, New England Journal.
Look at Tim Mikesell. So, press pretty common. I think probably, those that are on the wards with residents have probably quizzed the residents about this many times as they've gone through. But, people have a lot of seizures, neurologic problems, the blood pressure is very elevated and out of control. Obviously got to think about it. Tim, I know that you like this one here, so you're going for 40 here, my friend. All right, picture this. Look at this thing right here. Name the symptoms. Oh, boy. Where's this, what's this location? What do you think the symptoms are? And so what's that syndrome called? Beautiful. This is a bright group here. Pain and temperature, loss, Dejeran-Roussy syndrome. Tim, where would you like to go next?
From AAN
50. Well, we're going to start at 10. Thank you. Never ask me a question. All right, look at this guy here. Look at this good-looking guy here. Who's this famous neurosurgeon? The new face of neurologic and neurosurgical disorders in the United States. And what I understand now is he's an expert in the field of dementia. So let's move forward to dementia. So, if you've been reading anything recently, there's been a lot in the literature on biomarkers. So a blood biomarker scientists are evaluating for the use in the diagnosis of mild cognitive impairment and early stage Alzheimer's disease is what? Does anybody read about? So plasma phosphorylated tau 217 is coming out as a marker. A pretty large study was done that's obviously going to have to be corroborated. Unlike stroke, 57 of these studies didn't come out at the same time, but it's a little more straightforward here. But this is a biomarker that in general showed much better predictive value than primary care physicians and neurologists in predicting Alzheimer's disease, which then begs the question of, are we going to use one of these blood biomarkers? So this is pretty exciting stuff, but it's really going to change. There's got to be a lot of thought in terms of how these things are used, but it won't be long before the primary care physicians are ordering this on everybody over the age of 65 as it goes through. So there's another, within the same article, another blood biomarker for Alzheimer's disease called the amyloid 40-20 ratio, the amyloid 20-20 ratio, or the amyloid 12-2 ratio. Which one is it? So the amyloid 42-40 ratio, out of the same paper, looked at another biomarker that could be done, and it measures two types of amyloid proteins. It's another biomarker of Alzheimer's disease. And again, these things in conjunction doing better than either one individually. So question 40 won't surprise you. What is the amyloid probability score, do you think? Well, we'll cut to the chase, but it's a combination of the amyloid and the tau tests that we just went through. So if you then, they're looking at this probability score of measuring these and then doing a score with it to determine what's the risk of somebody developing Alzheimer's disease. So very exciting stuff that's coming out, but you know, your PCP is going to start ordering this stuff, so start thinking about it, look at it, because there could be a big deluge of these things. When you look at the literature and they talk about how long it takes someone to get neurocognitive testing, or heaven forbids any type of nuclear medicine imaging or lumbar punctures, this takes months and sometimes even years to get this stuff done. But you know, they can get a blood test tomorrow. It may take a little bit of time to get it back, but this is going to really revolutionarily change how things are, how patients are diagnosed. And then it's going to be up to everybody what you're going to do with these patients. But, you know, it's changing times. So, Tim, you wanted number 50?
Please.
Okay, here it is. So what does ARIA stand for? I heard part of it. Yeah. So amyloid-related imaging abnormalities, and you can see a picture of it over here. People that have the ApoE4 are at a higher risk for this. So if you know they have this abnormality and you're going to put them on these medications, you're going to see a higher incidence of this in this patient population. You see this usually temporary swelling in areas of the brain that usually resolves over time. Not always. You can see some blood products there as well. Tim, where would you like to go? Drug diagnosis 10. All right, these drugs that are very hard for me to pronounce are used for treating what disorder? Excellent. So spinal muscular atrophy. And again, the great thing about this is there are new drugs coming out all the time for these disorders that we had nothing that we could give to patients, and now we have medications that can be used. Tim, where did you want to go?
Category 20.
All right, I like your thinking. Well, Susie kind of mentioned this a little bit, but this came up in the previous talk, and that's the use of cannabinoids in epilepsy syndromes. And Susie mentioned, so I guess I'll take three answers here because she also mentioned tuberous sclerosis, which I did not include here. But do you remember what she said, the two disorders? Yeah. So Dravet and Lennox-Gastaut, and Susie mentioned also tuberous sclerosis with that. Tim, I know you're going to 30 here. Oh. What's this drug used for? Alzheimer's. Now again, it's not an area that I work in, but it's interesting reading just even the lay literature on this type of stuff. I get things all the time. Drugs released, it works, it doesn't really work, we're pulling it, we got no drug left, we're going to let people stay on these drugs. It's really the Wild West out there with these drugs at this point. We'll sort of see where the dust settles with all of these drugs. Is anybody using this drug? Anybody used it? Okay, so there's several people that have used it already. What's your experience with it? Getting it, insurance covering it? Medicare? Oh, okay. Medicaid? No. Okay. Yeah. So the statement was it's a real hassle, takes a lot of time. Now, that's always the way it is for a lot of things that are new. So, you know, once more data comes out, there's better evidence that these things are helpful, then those things will sort of take care of themselves. If the data doesn't show that, then those things won't go away. Tim, I know you're probably thinking 40 over here. It's like we're on the same wavelength. I'm Kreskin. You guys are, most of you are probably too young to know Kreskin, but not you. Yeah. Bevacizumab, back to my area. Anybody know this drug? So this is a VEGF inhibitor, and it's used to treat multiple cancers. So it affects vascular endothelial growth factors, so it was a drug that is used in glioblastoma a lot. It's used in a lot of systemic cancers, but probably its greatest utility is that it is used for treating radiation necrosis. There's a Class 1 evidence and randomized controlled trial looking at use of it in patients who had radiation necrosis versus no radiation necrosis. It is an excellent drug at decreasing brain edema and swelling. The problem is that some of these patients spend time with Blake in that there's increased risk of stroke, there's increased risk of press because the blood pressure can go up, there's increased risk of venous thrombosis, blood clots in the lungs, blood clots in the legs, and there's some case of bowel perforation. So they can cause problems, but like a lot of things, those that have the greatest efficacy oftentimes also have the greatest risk. So I'm not...
Can you use that in combination with other chemotherapies or not?
So Blake's question was, if you use bevacizumab, it's an intravenous medication. As you noticed, it's a MAB, so it's a humanized monoclonal antibody. Can you use it with other medications? It decreases interstitial fluid pressure, and even though it closes the blood-brain barrier, it actually allows blood vessels to have a little bit more room because they're not being squeezed as much now by all the fluid that's around them. And in some ways, maybe drug gets better penetration through these blood vessels. So the answer is yes, you can use other chemotherapies in combination with this. Now, if you have drugs that have a significant risk of bleeding or those types of things, or clotting or affecting that, then you'd have to decide, are you adding too many side effects? Now we made our headache friends helpful. So I think tomorrow morning we're going to discuss this. Tomorrow morning, you'll notice on your badge that everybody has something written on the bottom. Mine says Salon 1, but if you haven't noticed it, you'll notice you have something on the bottom of your badge. And you'll be broken into 3 groups. One will be here, the other 2 will be in different rooms, and the speakers will move. So you'll stay in the same room that you're in for an hour, and we'll have a more interactive, smaller group interaction. Headache is one of them, dementia is one of them, and movement disorders is another one that we're going to do tomorrow. People generally like it. It's a fair amount of fun. It's a much better opportunity to have interaction. The good thing about the other rooms is they're smaller, which sort of forces more interaction. So if you're in this room tomorrow, the best thing to do is move yourself forward so it can get a little bit more interactive as you go through. Tim, where would you like to go? I'm done that one, so rhyme time. Okay, so now these things have to rhyme, okay? Used in the closet, white matter disease. And what's the first one? Coat hanger. Yeah, I heard someone say coat hanger, binswanger. Huh? Yeah? What, it's silly? Did someone say it's silly? I'm offended if that was possible. Oh, now we're talking alcoholic drink, alcoholic's disease. Anybody? Who's got the fast mind out there? Oh, I like Macchiafavi Bignami. That's not the answer here, but we'll get a little bad Chianti. Well, oh, okay. So what's the first one? But they got to rhyme. What's alcoholic that would rhyme with Korsakov's? Smirnoff. Smirnoff, of course. I know. Another one? Sure. Oh, you'll love this one. Love this one. Extensively hirsuate, vitamin B1 deficiency affecting the nervous system. Oh, you guys are so good. Very hairy, berry. That is hairy. All right, Tim, I know you want to go to 40. Stop something from developing. Neuromyelitis optica spectrum disorder. Deep six divix. I know that's a tough one. I got to do something with that one. I know. I wanted to get rid of that one. I couldn't think of a new one. But if somebody has a better one, come to me. It's easy to criticize, but let's make it better. Oh, come on. You old guys out there, you got to know this one. Female comedy actress of the 50s, lack of ceramide trihexidase. Who is this gal? Oh, a what? Yes, it is Fabre. I know. Once you hear it, it's just so obvious. All right, Tim, I think we're going to have to go here before we go to double jeopardy. How's our time? Do I have to speed up? We're doing okay. We got 20 minutes, 19 minutes. All right, now Bobby talked about this. Who's this guy here? Who's this guy here? King George's madness. What made him mad? And what's the significance of this over here? Yeah, what is this over here? Yeah. So I do distinctly remember years ago going to an intensive care unit, and some patient was intubated in the bed, and they took their urine and put it up on the windowsill, and it turned black, and the person had porphyria. So acute intermittent porphyria. And again, who knows what Van Gogh really had, right? When you read the Van Gogh literature, he had every neurologic related problem as it went through. But, you know, it makes for a good story. You just, whatever you want, you just make it up. That's what Trump does. I'm not going to, it's not political. Craig, could you remove that stuff? All right. Tim, I'll probably go over to 20 here. All right, who's this guy? He developed EEG. Hans Berger. Now, Hans, I really kind of question about putting this in because Hans Berger, German epileptologist, has a very checkered past in terms of his relationship with the Nazi regime. And a little dicey activity went on after that. So he did a good thing developing the EEG, but after that, not so sure. All right, all right. Nerves affecting in the jugular foramen. So what nerves go through the jugular foramen? Numbers, please. 11? Can you give me more? 9. Okay, anything in between that? You are correct. 9, 10, 11. Well done. They also call it this Wernicke syndrome. I don't think anybody does. Unilateral vocal cord palsy. Winging of the scapula. I did actually a gamma knife case on a patient with a schwannoma affecting the jugular foramen probably a couple of months ago with it. So we certainly see these things show up. So number 40, oh, my husband has been replaced by an imposter syndrome. Yes. What's the movie here? Anybody remember this? What this movie's from? No, that's a good guess. Invasion of the Body Snatchers. Which, if you haven't seen it for a long time, it's kind of interesting to see because number one is so hokey as you go through, but it's kind of fun to watch some of these old movies again, but it's sort of on the same thing of this. And in this case, had been replaced in the pods. All right, 50 before we go to the ever-exciting double jeopardy. Whoop. All right, settle down. All 4 manifestations of Gerstmann syndrome in the dominant angular gyrus. What are the 4? Right, correct. So agraphia, acalculi, finger agnosia, left-right disorientation. I always liked, back in the day, to rough the residents up about that. All right, so let's move on to double jeopardy. Tim, what would you like? Oh, boy. Doesn't everybody like dizziness? No. Elements of the hints test. Test of skew. Yep, good. All right, let's go down this path. Kind of mentioned this one a little bit with Blake earlier. Cortical blindness? Exactly. So Blake had a patient that had some visual field stuff, although it had a different mechanism that he presented. Oh, what was that movie there? That's exactly correct, yes. Just a flesh wound. So that's the relationship between the two. Dizziness, small pupil, swallowing difficulty, and facial numbness. Lateral medullary Wallenberg syndrome. Well done. Well done. Blake, you got them all primed up in the stroke area. And we even have Know Your Stroke category. We haven't even got to that yet. Well, wait a second. Oh, look at that. Sorry about that. I guess I gave that one away. I hit it a little too quick. But it's kind of fun, so let's do it one more time. So you don't want to de-hiss your canal. Going to make you dizzy as you can get out. I'm getting tired up here. Oh, here we go. From my headache friend, not to give it away, the commonest cause of episodic vertigo. Vestibular migraine. Listen, if you're going to fight me about it, we'll have to talk later offline. All right, 100 points. This could make or break someone's day. Brainstem infection causing dizziness. I heard it, yeah. Listeria. Right there. Good. All right, Tim, where do you want to go? Think quick. All right. What's the disorder? Charcot-Marie-Tooth. Excellent. Think quick. Ooh. CMP. Central pontine myelinolysis. In the epilepsy talk earlier, you know, people are on oxcarbazine. You can see it with the other sodium channel blocking drugs. I've seen plenty of patients over time that have low sodiums. You got to be careful how quickly you correct that sodium. Oh boy. Whoop. Cortical riveting. Could be. Could be. So Blake said anoxic. Could be that. Seizure, you can see it, although, you know, you'll usually see, I didn't show you an enhancing scan. If you would have had a GAD scan, you see more of the cortical enhancement that's there. But this is a picture that you'll see with CJD. But we'll give you some others. Oh, man, I'm hungry. What's this sign? Associated with? So, multisystem atrophy and the hot cross bun sign. 100 points. Thinks, oh, this, anybody know what this is? Disease causing this. Japanese eponym. Yes. Good. Hariyama disease. Very nice. Tricky stuff there. Tim, where do you want to go? Learn your ABC. So again, A, then a B, then a C, then a D. Who's this guy? Did I get the wrong one there? Oh, well, I guess we know that one. Sorry, I must have poked the wrong one there the first time. Third nerve palsy and crossed ataxia. Starts with a B. Exactly. Bendix syndrome. I wonder what this one's going to start with. Episodic hearing loss and uveitis ending in deafness. Cogan's, very good, nice. Autoimmune rheumatic disorder with inflammation of the eyes and ear. Nice. You guys are good. Ah. Enlargement of the fourth ventricle, complete absence of the cerebellar vermis. There you go. Dandy Walker. I wonder what the last one starts with. Oh. Pupil function nucleus. Edger Westfall. Good. You guys are up on your stuff. Tim, where do you want to go? Where do you want to go? Stroke? Here, get your A. Let's get our A. Oh. What are these pupils? What's the disorder? Irregular small pupils reactive to accommodation, not to light. Right. Good. Gonna have to make these harder. Metachromatic leukodystrophy? Yeah? Good. Nice. You guys are ready for your boards. Rheumatoid arthritis, spine disorder. Atlantoaxial dissociation. Yeah. Yeah, I could accept that as an answer. Number 80. Absence of the corpus callosum and West syndrome. Our epilepsy friends maybe know this one? There you go. So back in the 90s, I remember there was an epilepsy fellow, and this was his last name, and I always thought of this disorder every time I saw him, although I do not think he was related to it at all. Progressive fatal disorder in infants. Big head. Alexander's disease. Good. All right, we're almost there. I know the fun is almost ending. Know your stroke. Most important modifiable risk factor for stroke is hypertension. Let's control it. Let's measure it. Let's be serious about it. May cause mutism and contralateral leg weakness. Name the lesion. ACA infarct. Oh, here, I just put this in for Blake just because just because I know the day wouldn't be complete unless it was Blake. Do you know what this stands for? Dual antiplatelet therapy. Thank you. That was solely for you, my friend. Oh, where's this one? Hemiplegia, hemiesthesia, contralateral heminopia. This is a tougher one. Anterior coronal artery syndrome. All right, one more and then the dreaded final Jeopardy. Condition this and stroke occur in. We've actually already talked about the disorder earlier. Fabry's disease with angiokeratoma. That's a tough one. All right, so let's get on to Final Jeopardy. This is for all the stuff. Write down how much you want to wager. And if you get it wrong, you owe me that much money, okay? I'm going to put that out there right now. What is this? Remember, I'm a neuro-oncologist. What do you think this is? They usually have a case of this in the New England Journal of Medicine every few years. This is a blood vessel. These are tumor cells in the blood vessel. The question is, what are the tumor cells? If we were doing our ABCs, we would be at the second one. Intravascular large B-cell lymphoma. So they talk about it quite a bit. We see a case of it probably, well, again, you know, it's always a how often do you see it versus how often do you diagnose it. I guess we'll say we diagnose a case of it probably every 2 years. We see it. It can be pretty tricky to do. So that's it. That's the end of Jeopardy. Thank you very much. You guys did great. Just to remind you, so that those are interested, we can go right over to the Jefferson room. They'll have some snacks and various things there. I'm pretty sure they usually do. But there's going to be a talk on neuromyelitis optica spectrum disorder. It's going to be a small room, so lots of time to ask questions if you have them for that. And then don't forget, in the morning, if you're interested, 7:15, be in the same room, talk on CIDP. Have a good night. Try and stay cool. Thank you very much for everybody's participation today.